Good morning, everybody. Can you hear me? Great. Okay. Welcome. It's February 15th. My name's Joanna Katzman. Welcome to our New Mexico Office Hours Infectious Disease Echo. I'm a neurologist. If you are on video, fantastic. Please do mute your phone or video if you can. Fantastic. I would like to introduce my colleague, Dr. Carla Thornton, if she is on.
Hi, good afternoon, everyone. Carla Thornton here. I'm an infectious diseases physician at UNM and one of the associate directors of Project ECHO. Welcome today.
Fantastic. And yeah, just wanted to remind everybody that if you do have a video and don't have it turned on, please turn that on, as we love to really see everybody's faces, and it's certainly just fine to be able to eat and drink. As many of you, this is your lunch hour. Wanted to give you a quick, some quick housekeeping items. Kent Noseworthy is our digital librarian. He's going to be copying and pasting a lot of evidence-based, evidence-guided material into the chat. Please feel free and get that information and use that as you wish. 45 minutes after the hour, you'll be receiving the CME link, and you can obtain your no-cost CEU CME credits. And if you don't need that, please consider just filling out that, as we do take a lot of time to look over this information and try to improve the program. Wanted to now turn it over. I'm going to make introductions for our subject matter experts as we go along. First, I'd like to introduce Marla Sievers from the New Mexico Department of Health. Marla's an epidemiologist, and she's going to begin today's session. Marla.
Thanks so much, Joanna. Nice to see everyone today. I actually have a PowerPoint today, which I don't normally, but I had a lot I wanted to update on, and so it was mostly just to keep myself organized. Next slide, please. So a few things that I wanted to update the group on, one being the federal pharmacy program expansion. And this has been in the media a lot, so people may have heard about it, and just wanted to let you know what was happening here in New Mexico. So there is an additional allocation of about 1 million doses that will be going out nationally from HHS of vaccine. And this will be allocated to states based on population. And this really expands the retail pharmacy component of vaccine distribution. So additional supplies, so this is above the allocation that the state is currently receiving, will be shipped to 21 national retail pharmacy networks. And as supply increases, that should expand to include over 40,000 retail pharmacy locations around the country. So the goal of this is to create some additional distribution points so that we have really dispersed access to vaccines and we don't create bottlenecks by having constrained distribution points. The state guidelines for who's eligible to receive vaccines still apply. So even though this is an additional allocation that's going to a retail pharmacy, each state's guidelines for eligibility still apply. The New Mexico Department of Health has included retail pharmacies in our distribution network since the beginning of our vaccine rollout. So we have sent some of our state allocation out to retail pharmacies around the state to increase access, especially in rural communities. Currently, the federal pharmacy partner for New Mexico is Walgreens. They're the only pharmacy chain that's currently signed up in New Mexico for this additional vaccine distribution, but hopefully we'll have more coming online. And then the second part of this federal pharmacy expansion involves federally qualified health centers. And so initially this week, there will be additional supplies. So again, this is above and beyond what a state is already receiving from HHS, shipped to federally qualified health centers. This is going to start out pretty targeted. It's a small rollout to only 25 FQHCs across the country. And when I looked at the prioritization of that, they're really trying to reach, it looks like FQHCs who are serving migrant worker populations, people experiencing homelessness, and other particularly hard to reach groups who may have been underserved up to this point. So as the supply increases, this is going to expand to 250 FQHCs around the country. Again, the idea is that you're creating these additional accessible distribution points. State guidelines for eligibility will still apply. Currently, there are no New Mexico FQHCs that are among these initial 25 sites, where this initial rollout this week of 25 sites does not include any New Mexico FQHCs. Unknown if we will be included in that next wave of 250. I'll keep you guys updated. But important to note that, again, Department of Health already includes FQHCs in its distribution network. So using the existing supplies that are coming into our state, we've already engaged our FQHC partners for vaccination in these high-risk populations. So moving on, CDC released some new guidance this week regarding quarantine after exposure in people who are fully vaccinated. So the first important point is that people who are vaccinated should still continue to follow all the current guidance to protect themselves and others. So they should still be wearing masks, distancing, avoiding crowded spaces, washing your hands often. So none of that changes just because a person has received 1 or 2 doses in the vaccine series. However, there was a change that vaccinated persons who are exposed to someone with suspected or confirmed COVID. So remember that normally we would tell that person they need to quarantine for 14 days. If they're fully vaccinated, so more than 2 weeks after the receipt of their second dose in the 2-dose series, and are within 3 months of having received that last dose in their vaccine series and have no symptoms, they don't need to quarantine. And this was a little bit confusing when this guidance was released, because to me, saying within 3 months seemed to suggest that they think vaccine immunity only lasts 3 months. And so there was a lot of conversation about this at a CDC call on Saturday, actually. And what they clarified is that this was sort of an interim step to align this no need for quarantine guidance with people who are within 3 months of natural infection. So it's not meant to imply that they think vaccine immunity only lasts 3 months. And there will be, further information coming out about quarantine guidance for people who are fully vaccinated as more data comes in and can be evaluated about how the vaccine is performing in real world conditions, and about its effectiveness, of course, against these variants of concern. So if a person doesn't meet these 3 criteria, so a person who is exposed, for example, who may become symptomatic, they should quarantine. So you need to meet all 3 of these criteria to be exempt from quarantine. And there's an important exception to this. People who are hospital inpatients who have been exposed should continue to quarantine, and residents in long-term care facilities should continue to quarantine after a known exposure. And that's just recognizing that increased risk of exposure to other people should that person develop illness. So no change to the isolation guidance for confirmed cases. So this really is only in regard to quarantine for people who are exposed to a case. If you are a confirmed case, you have a positive viral test for SARS-CoV-2, no changes to the isolation guidance. You would still need to isolate regardless of your vaccination status. And then I wanted to announce we've begun CDC and at the state level our COVID vaccine breakthrough surveillance. So obviously, we are very interested in people who are fully vaccinated, so 2 weeks past their second dose in the series, who go on to develop infection. So we want to know about those cases as quickly as possible so that we can obtain their isolates from the laboratory for a whole genome sequencing, because part of what we'll be looking at is, is this a variant infection? And that explains the vaccine breakthrough, or, are there certain groups, age ranges or other demographic groups, which are disproportionately represented in vaccine breakthrough. So that'll be important for us, understanding the efficacy of vaccine in real world conditions, and also to try to answer this question about, does vaccine just prevent symptomatic disease, or does it also prevent infection? So if providers become aware of one of these breakthrough cases, we want to know right away. There is a HAN that's being drafted that will be out, and with further instructions about how you notify Department of Health and help us obtain those laboratory specimens. Next slide. And then I wanted to update the group. This pertains to the case presentation that Dan Smith from New Mexico Behavioral Health Institute presented a couple of weeks ago with the woman with the delayed hypersensitivity reaction. There was some discussion a couple weeks ago, I think, or last week at the ACIP FDA meeting about these delayed hypersensitivity reactions. These were observed during the Moderna trials. And you can see some people had delayed injection site reactions on or after day 8 is what they're defining as delayed. And so less than 1% of participants in the trials experienced this, after their first and second dose. And the reactions were typically erythema, induration, tenderness, and they resolved over the following 4 to 5 days. So this was a phenomenon that was observed during the clinical trials. And CDC updated their guidance this week to include some direction for people who might experience one of these delayed hypersensitivity reactions after their first vaccine. So ultimately, they don't think that this is a contraindication to receiving your second dose. The recommendation is still that those folks would receive their second dose. However, it should be administered in the opposite arm. And you can read more about that. I've included the link here. I won't spend a lot of time on it just because of time. And then lastly, we've updated the New Mexico COVID vaccination dashboard. I know some people were interested in more county level data. So you can now look at the map and you can look at county level data. And this is by the person's county of residence. And there's also some tables and graphs that show you age group stratification for who has received vaccine. The dashboard now also includes vaccines administered from federal partners like the VA, IHS, or Federal Bureau of Prisons. And again, I've included the link there. Thanks, everyone.
This is Joanna. Marla, this is just terrific, amazing information. Thank you so much. For those of us here kind of physically in New Mexico, this is fantastic information. And for those of you residing outside of New Mexico, Marla, where might are the clinicians on the network that are outside of New Mexico be able to get information regarding pharmacy distribution and such?
So if you go, and I think Ken already put it in the chat, there's the link to the Federal Pharmacy Partnership Program. If you go there, you can search by your state and you can see who the retail pharmacy partners are in your state, and also find information about FQHCs in your state who may be receiving this additional distribution of vaccine.
Great. Thank you, Marla, so much. And we have a lot of fantastic questions already coming in to the chat. And so keep them flowing while I introduce Nestor Sosa, our chief, who is the division chief of the infectious disease group at University of New Mexico School of Medicine. And Nestor has his PowerPoint just about ready.
Yes, thank you. Thank you, Joanna, and thank you, Marla. Let me put this in the larger. Okay, so too hard. Can you all see my slides? Okay, perfect. I have a lot of things to share, so I'm going to go fast so we can allow time for question and answer. For some reason, I found so many interesting preprints this week. So first of all, most of these articles are in the preprint or before peer review. So I just wanted to put this disclaimer because sometimes the articles change when they are finally published in the papers, not in the papers, in the journals. So these are what I'm going to talk. I'm going to talk about recent publication from New Mexico, actually on the 677 mutation, a new EUA for a monoclonal cocktail, a study of reinfection from Qatar that was sent by Dr. Miller, Stuart Miller, here in our group. Some data on vaccine effectiveness now, not efficacy, but actually effectiveness in Israel. A new result from the recovery trial on tocilizumab. The first evidence of decreased viral load after vaccination. something about the interval between doses, and the latest hope for a miracle cure. Just want to share some results on another drug. So first of all, I just want to congratulate the group that we have last week, Daryl, and Dr. Edwards, Daryl Dunman, Daryl Dinwiddie, and we're actually featured in the New York Times, I think yesterday, because they published their experience with the variant, the 677 mutation that they found here, and actually they did it with some collaborators in Louisiana and other places. So they already put out the lines here are moved, but they already put out the preprint. Is the emergence in the late 2020 of multiple lineages of SARS-CoV-2 spike protein variants with a mutation in the position 677, which is in one of the critical areas of the spike protein. And this paper has Daryl, Kurt Schwalm, Michael Edwards, and Daryl Dinwiddie that we had last week here. Basically, they described how these mutations in the position 677 have been increasing in the United States. We still do not know the meaning of this, but it's evident that it's been detected in the genomic sequencing, and it actually appear in different areas simultaneously with some differences. So their hypothesis is that this is just showing up in different places, probably offers some type of advantage to the virus because it's sort of what is called a convergence evolution, because it appears in different places without a clear relationship between the patients. So stay tuned for this. And they actually, I found this very actually poetic or nice. Instead of coming with all these complicated numbers, they actually name the different viruses or lineages of viruses with the names of birds to be easier to remember. So the one from New Mexico is Robin 1. But there's another Robin 2 that was isolated in other places, Pelican in Oregon, etc. So they're tracking these 677 changes in the virus, and they actually these different lineages they gave at least easy to remember names. So really nice imagination there. But this is very complicated, basic science, genomic studies. So hopefully we'll have them back in the future to explain in more detail. The other sort of news is that the FDA gave an EUA to the combination of bamlanivimab and etesevimab, which are two monoclonals for mild to moderate COVID in patients who are at high risk of progression. So, age over 65 or over 55 with some risk factors can now receive or are authorized to receive this combination, which it's more effective than bamlanivimab by itself. So the efficacy preventing hospitalization in these mild to moderate COVID was statistically significant and different from just bamlanivimab monotherapy. So it's sort of a step forward. Obviously, the EUA says that etesevimab should be used only with bamlanivimab, and it's not for hospitalized patients. So it's very similar to the bamlanivimab recommendation, just that it's a combination of two monoclonal antibodies against the spike protein. Dr. Miller sent us this article, so I'm going to review it briefly. I call it the mother of all reinfection studies. This is a group in Qatar which actually follow 40,000 patients with COVID to see if they got reinfected, essentially. So this is a cohort study out of Qatar. It's called SARS-CoV-2 reinfection in a cohort of 43,000 antibody positive individuals. So they had this population of people who already had a positive antibody, so evidence of all infection, and they followed them for 16 weeks to see if they got reinfected. And using different criteria, just having a positive PCR 14 days after the initial diagnosis with antibody, they found 0.7%. But if they apply the genomic evidence, so actually doing genetic sequencing of the two viruses, the one that was isolated in the beginning, the first time, and the second episode, they found only 0.1% frequency of reinfection. So very low, even lower than what we have seen in the UK. And this gives sort of an incidence of 0.66 by 10,000 person weeks. So definitely very low. Another thing is that they said that this protection didn't wane at least over 7 months, which is the observation period. And there was only one severe case. So most of these cases that occurred, like 129 cases, were all mild. So So if you had COVID once, at least you're relatively protected. And actually, the protection for reinfection is 95.2, which reminds me of the protection of the Pfizer vaccine. So if you got COVID, you have a protection at least for a few months. And this we saw in 2 studies from the UK, but now this one from Qatar of 95%. Unless you have some type of immunodeficiency, etc. But these are just general population in Qatar. The other important, I think, news also from the Middle East. As you know, Israel is the country with the highest percentage of vaccination. I think last time I checked, there were over 40% of their population vaccinated. And one of the areas actually published or actually communicated that out of almost 500,000 vaccinated people, only 4 have had severe COVID, and none of them died. So this sort of confirms the finding of the study, and this was mostly with the Pfizer vaccine, 0 death, and very rare, 4 in 500,000 cases of COVID in the vaccinated subjects. So hopefully the surveillance that we're going to do here in New Mexico is going to show the same. But I think this type of study are important. And in fact, they actually, and this is after 2 doses, full vaccination, 14 days after the second dose. But they actually published a preprint of an earlier experience. They actually showed that there was a decrease of around 50% in the risk of developing disease after the first dose, after 13 to 24 days after the first dose. So very early, even with 1 dose, you start seeing protection. And this is real life, real world evidence from Israel. So really encouraging news regarding, so a 51% relative risk reduction. So that's what the triple R means in the 13 to 14 days after the first dose in this population. Obviously much better after the second dose. But this was the earlier publication with the Pfizer vaccine there in Israel. The other study, if you remember, the recovery study was famous because it was the one that gave us the first evidence on dexamethasone. This is like a real life study done in many places in the UK. It's sort of an adaptive trial, not double-blind placebo, but actually open label. And this time they actually sent the pre-publication of this study using tocilizumab. Tocilizumab, we have discussed before, it's an IL-6 receptor inhibitor that is supposed to fight this cytokine storm that patients with severe COVID develop. So they did this study, the tocilizumab. They actually included adult patients with COVID-19, obviously with positive PCR, and they have to have pneumonia. So they have hypoxia, defined as less than 92% saturation in room air, and systemic inflammation defined by a CRP greater than 75. These were sick individual patients who are hospitalized with hypoxia and COVID, and they gave him either 400 or 800 milligrams depending on the body weight, and this dose could be repeated, and they compare that with the standard of care. See, there's no placebo. This is not a double-blind placebo control. It's actually, they compare against not receiving tocilizumab. And the great majority of these patients receive steroids. So this is steroids on top of, tocilizumab on top of steroid. And what they looked was the 28-day mortality. They enrolled patients mostly, throughout last year's epidemic in the UK. And the number of subjects is pretty large, 4,000 subjects, half in the tocilizumab, half in the standard of care. And you can see how sick they were. 14% were in mechanical ventilation, 41% were receiving non-invasive ventilation, and 45% only oxygen. So these were really sick patients. And they found a statistically significant decrease in the 28-day mortality from 33% usual care went down to 29%, which is sort of a 14% relative risk reduction. So a relative risk of 0.86. Not unlike we saw with dexamethasone. So interesting finding. There was also more chances or higher likelihood of being discharged alive in 28 days, and also less progression to mechanical ventilation. So this is another positive study for tocilizumab. The 28-day mortality, Kaplan-Meier, and the 20-day hospital discharge both favor tocilizumab clearly. And when you put that into all of the other studies, there are some studies we didn't show, so they actually all over the place. The study that have been done with tocilizumab, this one, because it's positive, the recovery puts the final tally favoring tocilizumab. So we'll have to see if the NIH and CDC decide on this now with this large 4,000 subject study from the UK. But you can see that some of the other studies really had no benefit. They crossed the one, except for the REMAP cap that I presented, I think, last week, and now this other trial from the UK. So interesting. We keep learning about tocilizumab. We have to wait. A couple of comments on vaccines. One of the probably hardest question at this point is, do vaccines decrease transmission? And also, if my second dose doesn't get here on time, am I going to die? So a couple of papers relating to this question. So this is the first evidence that there's a decreased SARS viral load following vaccination. These investigators actually compare the viral load of those these are vaccinated people who developed COVID shortly after the vaccination. So this meaning that they were probably incubating the disease when they were vaccinated with one dose, and then viral load after the second week of the first dose. Okay, and remember that CT, there's an inverse relation between the CT and the PCR and the viral load. So this is comparing the PCR, CT, or cyclic threshold in these two groups. Those who develop COVID like really early, so before the vaccine had any effect, and after a couple of weeks of the first dose. And you can see that the CT is higher, meaning that the viral load of those vaccinated was lower, and is the headline of this study. So patients who receive the vaccine and nevertheless develop disease, there's probably a lower viral load, and that hopefully will translate, because we don't have any direct proof, will translate into less transmission. And this is only one dose, really early, so we'll have to wait 2 doses, 2 weeks after, to see if this is replicated. I'm sure it's going to be that way, but we have to also see the data. But this is early data of how the vaccine can decrease viral load even if you get infected. Okay, so that's interesting. And they also compare with viral load of vaccinated versus unvaccinated comparators, and there's definitely several points in the CT higher for those vaccinated, meaning lower viral load in those vaccinated than unvaccinated patients with COVID. So interesting first evidence of decreased viral shedding, at least relatively decreased viral shedding in those who develop COVID despite vaccination. And another interesting study is regarding the interval. This is sort of an analysis from the Shadox vaccine, which is the AstraZeneca Oxford vaccine, is a chimpanzee adenovirus Oxford 1 vaccine, which is the one that they're using in the UK. And they published their data, and we discussed it already, but this is sort of, they stratify their patient by the time between the doses, because not everybody got the vaccine at the same dose, like in the Pfizer and Moderna. There were patients who received it less than 6 weeks, and all other groups who received it more than 14 weeks. And look at the surprise, more than 12 weeks was better vaccine efficacy, 84 versus 54. So this finding actually supports the decision of the UK government of spacing out the vaccines. They did it to vaccinate more people, not because they thought they were going to have better protection, but sometimes it's better to be lucky than good. They were lucky, and in fact, the protection conferred by a more longer interval between doses seems to be better, 84 versus 54%. And not only that, if you look at the asymptomatic COVID cases, and this is one of the first data on asymptomatic COVID cases, only those who received the vaccine separated by more than 12 weeks actually had a decent efficacy, 47% efficacy preventing asymptomatic disease versus basically nothing. I mean, it was worthless, no effect, no efficacy in preventing disease if you got the vaccine too close together, the 2 doses too close together. So interesting finding from the AstraZeneca vaccine. And the last thing that I'm going to share is, and I put the title, Still Looking for a Miracle Cure, because we're still looking for better drugs than remdesivir and some of the other immune modulators. So I already presented, I think, several months, a small trial on fluvoxamine, and I haven't heard anything more about fluvoxamine. And in this group, I I think out of California, did a study. It was sort of a quasi-experimental study. They had an outbreak in a workplace, and they offered fluvoxamine to all of the people, to all of the subjects who had developed COVID in this outbreak. And more or less half of them, 65, opted to receive the drug and 48 declined. So it's sort of a pseudo placebo control study, because it's really not a placebo control. It was open label, but it's interesting that some subjects say, no, I don't want to receive anything, and others did receive the drug, and they followed them. These were subjects with mild COVID, and they followed them, and obviously, interestingly enough, nobody who got fluvoxamine, 0 of 65 were hospitalized, versus a much higher percentage in the other group. Let me see if I have the value here. So these are the distribution, sorry. So they found a significant difference between those who received fluvoxamine versus those who received no therapy regarding the risk of hospitalization, despite the fact that most of the people who decided not to take any therapy were asymptomatic, but they fared worse than those who received fluvoxamine, which mostly symptomatic. So a surprising finding, and it's the second study. So we're waiting for this large placebo-controlled study with fluvoxamine, early fluvoxamine. Fluvoxamine, it's used for obsessive compulsive disorder. It's actually a drug that is used by psychiatrists. It's not an antiviral, but it has some effect in some intracellular structure that seem to be important for the virus, according to the author. So interesting finding. I think that was the last one. Yeah, thank you. And we can go to Leslie. Thanks.
Nestor, thank you so much. Fantastic. Great presentation. Wanted to thank Marla also so much for answering so many of the vaccine and public health related questions. And for everybody on the network, thank you so much for chatting in so many great questions today. Dr. Domen, Daryl, are you on the line? Might you just wanted to publicly congratulate you on your paper. Are you able to just introduce yourself?
Sorry, did I just temporarily mute, or is somebody decided
No,
to like called upon? So all of a sudden the audio went out, and I was like, uh-oh, I think they
No,
might
we
be.
can hear you. Do you have a video, or are you on video?
Yes, just 1 second. Sorry, it's been a bit of a crazy day.
Oh, great. Well, congratulations. Congratulations. And if we're going to have Dr. Leslie, congratulations, Daryl. Would you just like to introduce yourself?
Sure. So I'm Daryl Domen. I'm in the Center for Global Health within Department of Internal Medicine at UNM. Yeah, I think I spoke, was it last week or the week before? Last week? It was just last week.
Yes, yes.
Days run together, like
Great.
most of you know. But yeah.
Thank you. We're going to have Dr. Leslie Hayes give her PowerPoint, and then Daryl, if it's okay, we might point some questions into your direction.
Perfect. Yeah, I have to run off to something at 1, but happy to take some questions before then.
Terrific.
Thank you.
Thank you, Daryl. Congratulations. Dr. Leslie Hayes, primary care provider and addiction specialist from Española.
Hey, thanks, Dr. Sosa. That was so cool. I actually have some hope that this may be over after listening to you speak today. So I just have a couple updates. I was going to be talking about the new study from the CDC about cloth and medical procedure masks. And during January, they conducted some experimental simulations to check 2 things. One was wearing a cloth mask with a medical procedure mask at the same time, medical procedure mask first, and then the cloth mask over it. And the second thing is just knotting the ear loops of a medical procedure mask at the edge and tucking and flattening it in, so that makes it fit much better. And it worked really, really well. Here's sort of, this is just a regular procedure mask. In the middle is the procedure mask covered by a cloth mask, which just, the cloth masks generally have a tighter fit. And so that helps. And then on the side is the fitted mask, where they've knotted it right at the very edge. And that just makes it fit much tighter. And so what they found is if you have a double mask or a knotted and tucked mask on a person who's coughing, it's more efficient at blocking the cough particles. If you have a regular mask, it's 56%. Cloth mask alone is 51%. If you have a cloth mask covering a medical procedure mask, it goes up to 85% of the cough particles blocked, and the knotted and tucked mask goes up to 77%. It's also more efficient at blocking exposure. They checked, if you had somebody nearby, how likely were they to be exposed, and it decreased the cumulative exposure of the unmasked receiver 82% if you had a cloth mask over a medical procedure mask, and 62% if you had a tucked knotted mask. And then they had the cougher be unmasked and the source be masked, and they found that it reduced the exposure by 83% if you had the double mask and 64% if you had the knotted mask. And then if you have them both with a double mask, it actually decreases it by 96%, or if it's both knotted and tucked, it's also 96%. So obviously ideal is if you can have everybody doing this. Even if you can't, you're still going to get pretty good. And this is just up top, if you have the value, if you have the unknotted medical mask, the basic, then the second is double mask, and you can see if the source is not masked and the receiver is masked, the difference between the two of them. If the cougher is masked and the other person's not masked, then it goes also down. It goes down a huge amount if you have both patients or both the source and the receiver double masked. And same thing with knotted masks. So I personally am convinced I am going to start wearing the double mask. I think it makes a big difference. Two caveats: you don't want a double mask if you're wearing an N95. Those don't need to be double masked. And also don't combine two disposable masks. That does not help. And then I wanted to talk a little bit about vaccine hesitancy. This was an issue even before COVID. In 2019, the World Health Organization actually named vaccine hesitancy as one of the top 10 threats to global health. And first study was just a preprint that vaccine hesitancy among healthcare workers. And at the time of the study that this was done, 36% of respondents were willing to take the vaccine as soon as it became available, while 56% were not sure. And vaccine acceptance increased as you got older, more educated, and as you had a higher income. Vaccine hesitancy among healthcare workers, lower acceptance was noted in women, in Black and Latinx respondents, and conservative Republican healthcare workers, also those working in a rural setting. Direct medical care providers definitely were more likely to take the vaccine. And the concerns that people raised were safety, effectiveness, and the speed of development and approval. And I just have to brag real quick that my rural, mostly Latinx and mostly female clinic had 81% of us have gotten our first vaccine. So we are way above these numbers. So I'm quite proud of us. And then I thought this was great. These are some evidence-based strategies for vaccine hesitancy from a Mayo Clinic proceedings preprint. And the first was just to make it convenient for people, policy level interventions. And I was so happy to hear Marla talking about what they're planning there, reducing out-of-pocket expense, requiring vaccination for childcare, school, and college attendance, participation in children. I think federally qualified health centers also, that makes a big difference. And then healthcare providers just need to recommend it, and we need to recommend it enthusiastically. They have found that if your healthcare provider recommends it, it results in a higher vaccination rate across a wide variety of preventive behavior, including vaccines. And we remain the most trusted source of information in general, and specifically in regard to COVID-19. And a recent survey, respondents indicated a greater likelihood of taking the vaccine if it was recommended by their healthcare provider. I must admit, I'm a little astonished at the number of people who I ask them if they are interested in the COVID vaccine. They give me 9 minutes worth of reasons why they don't want to get it. And they say, what do you think? And I say, I think you should get it. And they say, okay, I'll get it. And I'm just like, whoa, okay. And that's all it takes. So, next thing is to make sure we train healthcare providers. And obviously we want to know good facts to talk to people about them. But it's really important to train everybody in the clinic, not just the physicians and PAs and nurse practitioners. I have been astonished. I'm sure everybody has had this experience where you spend 20 minutes going through risks and benefits of a treatment with the patient, and they're really not sure, and they go up to the front desk, and the front desk says, "Oh, I see they're offering you this. That's a great treatment." And boom, the patient is totally convinced. So making sure not just that the medical providers are trained, but everyone in the clinic is trained really helps. And then using a positive frame where, for instance, with the flu shot, they say, we're going to give you the flu shot today rather than, do you think you want the flu shot? So just talk to them as though, you think they're going to want to do it. The other thing is to really talk about it in a positive manner, the benefits. You're going to protect your family and friends rather than you might get really sick if you don't get it. And they find that actually makes a difference. And then the other thing is, you don't want to directly argue against people's misperceptions because that can backfire and make them sort of dig in firmly. You want to try and frame the message in a way that affirms their worldview already and explain the motivation behind the misinformation and provide a factual alternative, and then repeat factual information. And one example I'll give of this is people frequently tell me, they don't trust the vaccine because it came out way too fast and they just don't trust the government. And my response has generally been to first off respond that, yeah, I can understand they don't trust the government around this, but to me, what it has shown is how inefficient the government is normally, rather than that they're being unsafe now. And then I talk about, sort of that it really didn't come out quite as quickly as they thought, that the mRNA platform had been in progress for many, many years before the COVID vaccine came out. And that, these are the steps that we normally take to get vaccines out, but normally there's huge delays in them as, people wait in committees, that this time they just decided, not to have these delays. So it really is more a case of this being very efficient rather than them being unsafe. And I find people actually understand that because it's talking to them about their thing. And in general, what I found with misperceptions is when somebody is talking, you want to leap right in and say, that's not true, but let them talk, give them as much time as they want. And first off, they're going to feel that you really heard what they had to say, because if they think you're not understanding what they had to say, they're going to ignore anything that you have to say about to contradict them. But if they really feel heard, then oftentimes when you say, well, have you considered this and such, it really makes a difference. And so I think that's really important if we're going to talk about vaccines with people. And that was everything I had.
Thank you, Dr. Hayes. Carissa Colbreth, Dr. Colbreth, are you on the video today? You on the call? Well, if Carissa's on, I think you're still on. I was going to have you introduce yourself. But Carissa's the medical director of Tricor Labs, and I think she might be available for some questions as well, but I'm going to quickly turn it over to Carla for the multiple questions that we have. So take it away, Carla.
Thanks, Joanna. Thank you, everyone, for all of these great questions. There's a lot of them have been answered in the chat, so please pay attention to that because Marla's putting in a lot of great information. Actually, Daryl, I wanted to ask you this question. Since you're on and we have you as an expert right now, one is a question from Alana Benjamin. How much genomic sequencing surveillance is happening routinely in New Mexico right now?
Yeah, that's a great question. So we've really ramped up efforts since the beginning of December through January. So we had a bit of a lull between the UNM group and DOH in October, November, sort of when everything, in our peak, when access to samples was sort of trumped by testing, rightfully so, during the peak. But we're currently sequencing somewhere between 200 and 300 per week between the DOH lab and the lab here at UNM. So that I think we're on track to sort of hit at least 2 to 3% of all positive cases in the state, which this certainly puts us well within the top 10, and depending on the numbers, even top 5. So we're doing really, really well comparatively, where the national baseline is something like 0.3% of all positive cases. So I'm really proud of our efforts here. And I think that's largely why we were able to detect these variants, much sooner than many other states. It's not that they're not there. It's just that we're, sequencing now at a level to actually detect these much faster and much earlier than a lot of states.
Excellent. Thank you so much. Carissa, I do see that you're on. I don't know if you had any other comments about that, about testing.
No, so we continue to work with Daryl and UNM colleagues on getting samples for sequencing to be able to see what's happening in the state. And we are investigating with the new variants that they've identified. We take residual of those samples and test them on our assays to ensure that we're able to detect those variants on our assays in the laboratory. And at this point, we haven't seen any issues that we've been able to tell so far with detecting any of the variants that have emerged. But we continue to have the collaboration with our amazing sequencing group to see if there's an impact on the clinical diagnostic tests. So far, we've not seen any issues.
Thank you so much. And I also want to congratulate Carissa because there was a really great article on her about in the Albuquerque Journal about her this morning. So congratulations for that. Okay, Nestor, could you explain David Tempest asked if you could explain the Israeli Pfizer study that confirmed 95% effectiveness, but also that vaccinated people reduce infection spread.
Right. So the paper was basically analyzing the viral loads of those who developed COVID early after vaccination. So I think they divided the day 1 to 13 and then 14 to 24. And what they found is that those who developed COVID later after the vaccine had a significantly lower viral load or higher CT values in their PCR. The only caveat is that we don't know really the exact translation of those CTs to viral load, and if that means that they're not infectious or they are still infectious. That's like another step. They just analyzed or gave information on the CT of those two groups of subjects, those who develop COVID early or late after first dose. Common sense tell you that, the lower the viral load, the less likely you are to transmit, but they didn't really gave detail because they didn't actually measure transmission. They just measured the viral load on those with COVID.
Great, thank you. And Nestor, will I have you, Nancy Gress's asking if we have any information regarding bamlanivimab effectiveness with the new variants.
Well, I don't know. I don't have information. Maybe Daryl can comment. I know that there are some of the mutations, especially the ones seen in California, that seems to escape some of the monoclonals because they are the mutations in the region where these monoclonal antibodies are directed against. But I haven't really read anything specifically about bamlanivimab and, for instance, the South African and the Brazilian or the UK variant.
Thank you. And there was a question just knowing, even anecdotally, is there are we seeing a difference between the two, the Pfizer versus the Moderna, in terms of the reactions that people are having, the site reactions?
Yeah, what I have seen published from CDC is a slightly more frequent anaphylactic reaction with Pfizer than with Moderna. It's with the earlier vaccination here in the US, they actually tally the number of anaphylaxis with one and the other, and there was a difference in favor of Moderna. There was less severe allergic reaction with Moderna, but both of them had this complication of anaphylactic or immediate allergic reactions.
Thank you, Nestor. Cami McKinney asked, are there any studies showing so far for increasing the time interval between the first and second doses of the mRNA vaccines?
Right. The only one that I've seen is the one with the AstraZeneca, the one that I presented. They actually almost accidentally had different intervals because they ran out into troubles with the manufacturer of the vaccine. So some of the patients in the study actually wait longer than was stipulated by the protocol. So they were able to retrospectively analyze that anomaly, and they actually discover that the longer interval did better regarding vaccine efficacy. And this is something, this is not new and it's not surprising. If you ask an immunologist, there is, the longer you wait, the more maturity of the immune system. So the booster, it's better. The reason why Pfizer and Moderna selected those short intervals is because they wanted to finish the studies earlier. We have commented that. It's not because there's a magic in 21 or 28 days. Yeah, and we know from other vaccinations, longer intervals are even more effective, but this is a pandemic, and they decided to basically shorten the interval to 3 and 4 weeks, respectively.
Great, thank you. And Leslie, there's a couple of questions about the masks. I don't know if you saw this, but why wouldn't 2 disposable masks be better than 1?
Because the way I understood it is that the procedural mask provides sort of better filtering efficacy, but they're not fitted as well, and the cloth masks are better fitted. And so the procedural mask provides better filtering, and then the cloth mask helps it to fit better. And that's the reason for that one.
Thank you so much. Joanna, I'm going to turn it back over to you for more questions.
Carla. Marla, there's a bunch of questions and Nestor as well about breakthrough COVID after someone has had a vaccine. And I'm wondering, Marla, especially in New Mexico, if you have any data from the Department of Health or from the CDC, perhaps about the numbers of breakthrough COVID illnesses after vaccination.
I don't have any specific numbers I can share at this point, but we do have reports that we're currently investigating of potential breakthrough infection in New Mexico. So we are seeing that phenomenon happen here among people who've already received their second dose and have gone on to develop mild disease. So we are investigating some of those reports currently.
Thanks, Marla. And the cases presumably are, like you said, are much more mild than what you would expect.
That's what we've seen so far in these early reports that we're currently looking into. Yes.
That's great news. That's great news.
Joanna,
yes.
I want to mention real quick that the governor put on her Facebook page this weekend that there'd been almost 400,000 doses of the vaccine given. And I don't know how many of those were first versus second, but I calculated that that's somewhere between 15 and 30% of adults in New Mexico have been vaccinated, which I thought was pretty darn cool.
It's really, Leslie, that's amazing. Marla, do you think there's going to be, based on that percentage of patients in people in New Mexico with vaccinations, do you think by that amount we're going to start seeing a reduction in the community spread of COVID?
And we've definitely seen a reduction in cases over the last few weeks. And, I think it might be too early to attribute all of that to vaccine. I think, we're seeing this reduction across the country. So I think there are things we don't quite understand about COVID yet, and we may, come to understand some sort of cyclical nature to these peaks and troughs and infection that we've not been able to tease out yet. I think we have, a large number of people who've been infected. So we've got some natural immunity, and then we also have vaccine immunity. So I think we kind of have all of these things coming together that are, the reason for our lower case counts right now. I don't think we can just say it's all vaccine. It's probably a bit too early for that.
Thanks, Marla. Does anybody, Nestor, Leslie, Carissa, Daryl, anything else to add on that?
No, just a comment on the breakthrough infections. I think, just looking at the trials, we knew that was going to happen. I mean, the protection was not 100%, and the reasons are multiple. There, when you vaccinate a large percentage of the population, there are subjects with immune deficiencies or persons who are immunosuppressed. So those are probably not going to mount a normal response. There's also a biologic variability in the capacity to produce neutralizing antibodies. We have, subjects that have natural infection and they do not have neutralizing antibodies. So that's also like normal biologic, randomness. So that it's normal that if you vaccinate 1 million people, there will be a subject with infection or breakthrough infections, because not everybody develops a robust protection. Hopefully, and the evidence is accumulating, hopefully hospitalizations and death are going to be really rare. If the data it's actually proven the way the studies and some of the preliminary data from Israel are true, we're not going to see many deaths in vaccinated people secondary to COVID, at least not in the short run. Maybe when the immunity wanes or there's a new variant that escapes the control of the antibody, we may see again, severe disease, hospitalization, and death. But hopefully, and I underline hopefully, the data that we're seeing is going to be supported by the real life experience of no death and no hospitalization if you were appropriately vaccinated and you do not have like an immune deficiency or something that really impairs your ability to respond to the vaccine.
Thank you, Nestor. Fantastic. Harry Seibold asked, can those breakthrough infections causing only mild illness be shedding large amounts of infectious virus? Meaning, can we still have kind of a super spreader event from these patients that have had kind of 2 doses of COVID vaccine? Good question.
Yeah.
What do you think?
That's a good question. I think remains open. Although I'm biased, the more I read, the more I'm biased towards to say no, that's not going to be the case, or it's going to be rare. But we have to be, attentive, because this virus have already surprised us in many, many ways, showing, airborne transmission, multi-organ dysfunction. There's like 10 or 12 surprises. So I don't want to be overly optimistic, but I really, would like to think that in fact there's going to be rare, like widespread transmission after you're fully immunized.
Right. Thank you, Nestor. Stuart Miller asks, any new updated information from VAERS, the vaccine adverse event reporting symptom, in addition to kind of what we learned today from you, Nestor, about Moderna having a little bit more increased sensitivity reaction?
No, I haven't seen any new MMWR publications regarding the vaccine reporting adverse event, and it's Pfizer, the one that has a little bit more, not Moderna. So Pfizer was more frequent, like 1 in 100,000, as opposed to Moderna, which was 2.5 per million, so it was less. So 1 in 400,000. Those are easy to remember. 1 in 100,000 anaphylactic for Pfizer, and 1 in 250 or 400,000 for Moderna. So less frequent.
Thank you. Pamela Dayfern asked, can a surgical mask be inserted inside the pocket of a cloth mask to achieve the increased efficacy in reducing transmission? Leslie, did you read anything about that?
I was gonna say the answer is maybe. It just hasn't been studied. So,
Right.
And,
Okay.
Same with the filters. There's just not been any studies on them. So.
Okay, great. A lot of really good questions. Donia Orgaron asks, how long should you wear a mask if you have been talking, coughing, sneezing? I think you need to keep wearing a mask, Nestor. Yeah, absolutely. We're about 2 minutes to the top of the hour, and I wanted to let everybody know that the questions that we didn't get to, we'll kind of scrub and make sure we get to next week. But I'm so appreciative for all the questions that Marla got through today on the chat, and Nestor got through as well, and Daryl Doman coming on. Want everybody to know that Alicia Parada, who is an associate professor of internal medicine, general internal medicine, and she runs the post-COVID clinic at UNM. We talked about the long haul symptoms last week, and the biologic agents that patients can get before they go into the hospital, kind of hospital COVID. She's going to come on next week and talk about how to handle long haul symptoms and what she does at her clinic, but primarily what you might do for kind of post-COVID neurological symptoms, cognitive symptoms, headache, things like that. So she'll be on and give a short PowerPoint and also be available for questions and answers next week. She gave a great presentation to our critical care echo for COVID, and she's delighted to come back. And we'll have Nestor and Leslie on next week, and hopefully our other amazing subject matter experts. And we so appreciate all of you. We did have the CME go into the chat at about 45 minutes after the hour, and all the slides should be in the chat as well. And I just wanted to let you know a few more echoes that we have weekly, as well as a new one. At 2 o'clock today, we have the first responder echo. And that that continues on a weekly basis. It's the First Responder Resiliency Echo for frontline clinicians, physicians, nurse practitioners, PAs, and traditional first responders. And then beginning this Wednesday morning and for 8 weeks, Wednesday at 10 a.m. Mountain Time, we have a brand new series, Climate Change and Human Health, which should be fantastic. We have 48 practitioners from 48 states and 78 participants from outside of the US participating so far. I think you might have gotten a flyer in your announcement yesterday on that Climate Change Echo. So I think Nestor or Leslie, are there any last minute announcements before we close? Okay, fantastic. Carla had to leave a little bit early, but we'll see you all next week.